Thank you, Praveen. At the outset, I welcome all of you to this 21st of our update. I think having been introduced to the perplexity of allergy, and once we diagnose that it is allergic diathesis, then comes the strategy of treatment. So how do we normally manage an allergy? See, if say for example just an allergic rhinitis, what we start is, if possible, allergic avoidance. Avoid the place where you get irritated or you get a lot of sneeze or you get a lot of issues. Quite often, if a wise patient is given a guidance, maintain a diary, pick up when and where when you go you get these repeated allergies or sneezing. You identify the possibilities. If that happens, avoid it for 2 to 3 years, getting exposed to that, because usual memory of the immune systems lasts for 2 to 3 years. If you don't expose to that particular protein or allergen for a couple of years, there is a possibility the immune system may forget it, and once that happens, probably you are out of the possible problem. But till such time, we have oral antihistamine, nasal sprays, if required, intranasal corticosteroids, and combinations of these which we can use, or leukotrienes. But all these are, as we know, are symptomatic treatments, except the first step, avoidance, where if you really can be able to manage an avoidance for a couple of years, which is always difficult, and in that situations, probably you have a definite line of treatment, and then the definite line of management, where we can say you can modify the disease process, is the last possibility of allergen immunotherapies. When you go to the next possible, the treatment of asthma, again we use various symptomatic bronchodilators and antihistamines where it required, and also allergen avoidance where it is possible, inhalant corticosteroids and so on. And when it is too worse, we use IV steroids or IV bronchodilators, and with the other managements. But again, the definitive line where you can intervene is, if possible, avoidance, and then a possible immunotherapy. So that puts us to the crux, that one of the possible definite treatment when it comes to allergy is immunotherapy. I think my previous speakers have made it clear that allergy per se is an immune system disorder, where immune system takes a call to fight against an innocuous protein which otherwise is not harmful. The very basic purpose with which the immune system has been designed is to identify the harmful substances and to fight with it and to see that they don't further ingress into the system. But when these things goes wrong, then the allergy develops. So that being the case, if we modify, modulate or alter the way immune system responds, we can definitely get out of this disease. So that's why the immunotherapies are also often called as therapeutic vaccinations, and they are effective against IgE mediated allergens. So you need to be very clear, when there is an allergic responses, it is not necessarily always IgE mediated, but in majority, if you consider in 90 to 95% of the patients, it is always IgE driven or type 1 hypersensitivity, what we call as, and that is responsible for the allergies. If it is other than IgE, the immunotherapies of what I am going to discuss is not useful, but you need to use a different strategies. So the immunotherapy what we are going to talk, or what I am going to speak about, is the IgE mediated allergic diathesis. So as I said, it has a potential of modifying the disease, and many studies have happened with reference to this. So if you look back, when did this immunotherapy of allergy was thought about? It is as early as in 1911, the first trial of immunotherapy was done. Though I can say it was based on a different thought process, because that's a time when vaccinology started developing. We did found, and that's a time when the microbiology was in its peak of a thought process of any medical scientist. Anything that was happening to the human was thought to be microbial or microorganisms. That's the story even in autoimmune disease, because that's how gold entered into the management of rheumatoid arthritis, because there we thought it is tuberculosis. Gold was useful in interfering with the mycobacterial multiplication. They tried gold and found it useful. And so also that was the time when vaccine was going on, and vaccine used to be very useful when in preventing the infections. Hay fever was one of the major problems that was there at that point of time, because agriculture was the major way of life, not the industry at that point of time. And what the scientists did was he isolated the hay extract, gave a subcutaneous injection of the hay extract, and found that the hay fever started coming down. That's how the story of the allergen immunotherapy started. The first subcutaneous immunotherapy clinical trial happened in 1970 and 1951. That's the time when the first well-organized randomized clinical trial was done to show that SCIT works. The subcutaneous immunotherapy makes a difference when it is compared with the placebo, and gradually it evolved over a period of time that it definitely has a lot of role to play with reference to allergic and allergic disease. Somehow, it's not very popular among both the practicing physicians, with an exception of few allergologists, few centers of immunotherapy, few centers of immunology. Immunotherapy is not largely practiced. The reason is, as it is said that most often we take it granted that allergy is not a life-threatening disease. Of course, it impairs significantly the quality of life, but it's with an exception of few severe wheeze or a angioedema which chokes the throat, or goes for an anaphylaxis. We don't consider allergy as such a severe, serious disease, but it's not when the patient do suffer. So there is a way out with the immunotherapies which evolved over a period of time. So before getting into the immunotherapy, just to know how does the allergy develops, the step one is sensitization. Once the allergens enters breaking through the barriers and it is picked up by the dendritic cells, under the influence of different cytokines at that present, if it is IL-13 and IL-4 at that point of time, it stimulates and deviates the immune response more towards Th2 and secreting immunoglobulin E. Subsequently, when the allergen exposure occurs, already there is a sensitization where there is a production of immunoglobulin E, which would have occupied the mast cells and basophils. And once the allergen enters or the antigen enters, they go for degranulation, resulting in allergy. So you need to remember the IgE is little unique among the immunoglobulins compared to the rest of the immunoglobulins. Rest of the immunoglobulins gets attached to the receptor only after the immune complex formation. What I mean is, if antigen antibodies interacts, then only most of the other immunoglobulins, say G, M or A, they get attached to the cell of their target only after that. IgE is an exception. Once IgE is secreted, it goes and attaches to the mast cells and basophils even before their exposure to the antigen. Once the antigen gets in, what really happens is there is aggregation of the immunoglobulin E into a single plaque. After adequate concentration of IgE aggregation occurs, the degranulations of the mast cells and basophil occurs. So here, the difference between the two is immunoglobulin E is already with an hands on the trigger. That's what I always say, that the hand is already on the trigger with a ready push up. Whereas rest of the immunoglobulins puts their trigger only after encountering the antigens. In a sense, they are already ready to shoot. That's how the immune reaction occurs within a short period of exposure to an allergen. Whereas immune complex mediated, otherwise what we call as immune complex mediated hypersensitivity, it takes a delay time of 24 to 48 hours. The reason is immune complex has to form. After immune complex forms, they need to get into the cells. Once they get onto the cell surface, the immune complex reaction occurs. So there is a delay gap of basically because the difference in their physiological process. One is ready to trigger, the other one is takes time to put your hands on the trigger. So that's how here the first step is sensitization. Once the sensitization occurs, immunoglobulin E is produced in adequate amount, and once that happens, the Ig is already on the cell surface, ready to be triggered. Why I want you to know about this is one of the ways how immunotherapy works further. So subsequently what happens when the complex happens, they trigger two types of substances, sudden acute response substances and a slow releasing substances. Slow releasing substances are cytokines, acute responses are histamines and other group of things. They produce epithelial cells, mucin secretions, vasodilation, smooth muscle contractures and so on, producing varieties of clinical manifestations of allergies. So now, that being the case, as I said, we deliver the immunotherapy in two different methods. One is a subcutaneous immunotherapy, wherein we use the allergens in a form of a dilutions, which is injected subcutaneously, which can be administered in three different methods. The most common method, conventional, this is what most of us practice in India. Here the native extract of the protein, for example if it's house dust mite, the proteins which are sensitive or which are sensitized are extracted, and they are given at a dilution, starting dilution of 1 in 5,000, and the dilution is gradually reduced. So you go with a slower dilution, slowly you go on increasing the dilution to a certain point, and usually initially it is given twice a week, followed by once in 2 or 4 weeks, and then 4 to 8 weeks, and subsequently maintained at a time interval of 4 to 8 weeks. There is one more called rush therapy. Rush therapy is the name as it suggests, where patient is given an injections at a much more frequent interval with an intention to desensitize in a faster manner. This is something which we sometimes use with reference to drugs, which is very much required. For example, patient has allergy to penicillin, allergy to some of the drugs. Of course, now we have a lot of alternative to penicillin. In the time when penicillin allergy and there are much options were there with us, penicillin used to be desensitized using rush therapies. You can gradually increase the penicillin subcut injections, and that could, when you go by the 10th or 15th day, the patient get desensitized to penicillin, and then you can go back to full dose of penicillin. Currently, thanks to the research with antibiotics, we have such a huge array of antibiotics. If not allergic to antibiotic A, you have another proteins to have. So then you have a cluster. The cluster type of desensitization is used when an individual has sensitivity to more than 1 or 2 antigens. It's not necessarily always sensitivity is to one single protein. One may be sensitive to house dust mite, sensitive to cockroach, sensitive to food. So when you have multiple sensitivity, that's the time when you use cluster method, where you use multiple different antigens in different concentrations to be introduced for desensitizations. And then goes over a period of time. If you remember from the history, what we got was the subcutaneous, because that's what all started in 1911. As I said, vaccine was always delivered by subcutaneous injections. That's why the first thing what we got was subcutaneous. But subsequently, as immunology evolved, as we start understanding about the immune tolerance, we started realizing that anything which is taken by mouth, as a matter of fact, the immune system tends to ignore it. I mean, look at the evolutionary's intelligence. Anything what we expect to eat through the mouth is something what we eat as a food. So responding to food is not something which is expected for the survival of the organism. So that being the case, the evolution has developed in such a manner, anything which is mouthed, anything which enters through the mouth, not to respond very aggressively. So that's why the mouthing or eating or giving an antigen through the oral mucosa should or expected to produce a tolerance. And it's not just that. First 6 months to 1 year of the childhood, exposure to antigens, especially through the oral route, is supposed to produce a tolerance for the lifetime. So that's why there is a new hypothesis, what we call as hygiene hypothesis. If you keep the child more protected, overprotected don't let the child to play on the grounds and the dust, if you don't give the exposure to the regular food for the lifetime what the child has to eat, may result in the development of allergies. So that's one of the hygiene hypotheses which puts it, and also the studies and observations very clearly says that, for example, I think one of the question asked us, the individual who he migrates to US, does he change the allergic tendencies? The second generation of Indians who have migrated to US have developing peanut allergy, which is a very rare entity in India. The reason is, most of our children are exposed to peanuts by the time they become 6 months or 1 year, because we use peanuts in every other food, and it's either used as a part of a masala or it is used as a part of it, or somehow the exposure to peanuts when they thrive and grow in India is much higher than when they go and adopt a US culture where the peanut exposure is late in their course of life. So that being the case, that's one of the reasons why we thought that probably if you give the same antigen through the oral route, there is a possibility of desensitization. Studies clearly indicated yes, that can happen. And there is a lot of convenience when it compared to skit therapy, because skit therapy needs to be administered by health professionals. It has to be done under the supervision. There is always a possibility of a severe anaphylactic reactions when you give a subcutaneous injection, because patient is already sensitive to that and you are injecting the same proteins. So that being the case, that fear of anaphylaxis or allergic reactions is high when you go to the subcutaneous. So that's one of the reasons why most of the allergy immunotherapies are gradually getting shifted to what we otherwise called as sublingual immunotherapy or oral immunotherapy. So what do we do here? There is a gradual escalation of concentration of the antigens, which starts with a lower concentration and gradually increases. Dilutions again depends on the reactions. That is what we showed, the class 1, class 2 reaction, class 3, class 4, class 5. Higher the reactions, lower the dilution, and gradually scale up the dilutions. If it is higher the, lower the concentration, lower the response rate, then higher the dilution and gradually go in desensitizing that. So what exactly the sublingual immunotherapy, how does it work? When the allergens are put over the submucosa, they get absorbed through the lamina propria, and subsequently they are picked up by the dendritic cells, which in turn is going to present it to Th0 cells, which most of them are migrated to development of T regulatory cells or towards Th1 rather than shifting to Th2. So sublingual immunotherapies gradually increases the T regulatory cells and diverts the response towards Th1. With this exactly happens basically because dendritic cells are tuned to present it in a different manner in the mucosal membrane, and also the internal milieu in the subcutaneous and submucosal area, as I said, is more to say no to the response rather than yes to the response. So that being the case, the possibility of developing T regulatory cells are much higher when it is developed through the sublingual routes. So what are the difference between these two methods? SCIT is there and a SLIT is there. SLIT is sublingual immunotherapy, SCIT is subcutaneous immunotherapies. Commonest is we need to define the optimal dose. It's almost standardized both in liquid as well as in the SLIT. It depends on the underlying immunological response. There is induction of T regulatory cells by both, and the later immunodeviation from Th1 to Th2 to Th1 occurs, and it suppresses Th17 response. There is evidences for the disease modifications to both. So what does it differ? The difference is frequency and severity of the systemic reaction, which is high in SCIT compared to the SLIT therapy. One of the commonest trouble what we see sometimes in the SLIT therapy is when you introduce in the initial 2 to 3 weeks or 4 weeks, patient suggests irritation in the throat, irritation in the oral mucosa, which normally we circumvent by giving a preventive antihistamines in the beginning first 2, 3 weeks or first 4 weeks, and subsequently ask him to come out of that. Whereas SCIT, it has to be supervised because one of the worry or a concern, as I said, is a severe systemic reactions. Then clinical efficacy with the venom is much better with the SCIT compared to SLIT, whereas SLIT is a good one for food allergens, whereas allergens like the dermatophytes, mites, etc. is equal in both the groups. So you can try to choose whichever the person is practicing. There is proven effectiveness with the multiple allergen mixes with SCIT, but it is less with SLIT, because if an individual have more than 4 or 5 allergens, if you want to desensitize, you have a different method, what I said, cluster method. When it comes to the oral SLIT therapy, not more than 3 allergens can be simultaneously used. You should not use more than 3 allergens. We choose out of the list, for example, if some individual has more than 10-15 allergens, then we try to choose 3 commonest possible exposure. That's where the clinical discretion comes. For example, patient is allergic to say eucalyptus, also allergic to the house dust mite, also allergic to cockroach. At that time, we skillfully avoid the eucalyptus. We only try to focus on these 3, because exposure to eucalyptus, staying in Bangalore is once in a while. You can always advise him when you go to those kind of areas, wear a mask, try to avoid it. Whereas when it comes to these 3, it is impossible to get rid of house dust mite as well as cockroach. Whatever the best your house keeping goes on, even if your house is well kept, you may land up in office or in another place exposing to those dust mite and cockroaches. So that being the case, getting rid of that is difficult, and we pick those to desensitize rather than going into an unexpected type of things. So there, as I said, indications of the different commonalities. Again, allergic rhinitis, both are useful. Allergic asthma, both are useful. Venom, SCIT is better than the SLIT. Food allergies, both have a different difficulties, but we can say the SLIT is little more better. Dog allergy, cat allergy, currently SCIT is in more favored. Atopic dermatitis, both are of a doubtful significance, but certainly our experience is when you have a definite antigen, in atopic dermatitis, the desensitization process definitely works. So how does it do? See, what really happens when we use SLIT? So you can see there is a reduced frequency of Th2 memory cells, there is reduced mucosal eosinophil infiltration, reduced mucosal mast cell infiltration, IgE blocking antibodies develops which prevents and reduces the IgE, especially GA, G4, and IgG, they block the IgEs getting attached to the cells, and there is increased IL-10 and TGF-beta, these are T regulatory cells, and there is increased IFN gamma, especially which I said is more towards Th1 type of response. So we do these changes when we continue to use allergen immunotherapy. Usually it takes 6 months to a year for these to develop. So these are this one thing you need to look at is, we are very specific to say that allergen specific IgE is reduced. Sometimes patient may come back to you after starting the immunotherapy, and if you cross check the IgE level still may remain around 1000, 1200, but patient is symptom free. The patient is symptom free for many other reasons, because it's not just the reduction in IgE what they are looking for, because the SLIT therapy or sublingual immunotherapy or SCIT therapy do not reduce the IgE value significantly, but the allergen specific IgE is significantly reduced, and also you get the blocking immunoglobulins. Though IgE is in adequate number or a good number, they may not be effectively causing an allergen response. So what it means is the numbers are there, but they are not effective because there are different blocking mechanisms. So these are the changes that what is seen after you use the SLIT or SCIT therapy. IgE level may not significantly come down if you are keeping a track of that, but it would be good if it comes down. That's a point where you can do away with both SLIT and SCIT therapies to those patients. But as long as they are there, it's best to keep the desensitization process, that using these sublingual immunotherapies would be of great use. So other things which comes is the regulatory T cells. The development of T regulatory cells is going to downplay the immune response. And you need to remember that T regulatory cells are allergen specific or antigen specific. Unlike the other regulatory cells, the regulatory cells are like a suppressants only when they are exposed to those allergen. So this is one of the reason where the allergologists use their immunological perceptions and knowledge. See, the continuous exposure to the antigen is necessary for the respective T regulatory cells to be there in adequate number. So that's why when we are, and other thing is, if the T regulatory cells are triggered, the response of suppression is not very specific. I mean, there are two different things. T regulatory cells get activated only when they are exposed to specific antigens, but the phenomena of suppression is not specific. What it happens is, it can suppress any T cells, any B cells which is active at that point of time, because they are mediated through the cytokines. So that's why there is something what we call as cross desensitization occurs. That's where the intelligence of picking the antigen matters. For example, as I said, the house dust mite is very common, ubiquitous. It's almost available every day in and day out. Whether you like it or not, we inhale it, we eat it every day. So that being the case, exposure to these allergens is very frequent. Even after you discontinue slit therapy or skip therapy after 2 years, there is continued exposure to antigen. Once you create the T regulatory cells, the continuation of the T regulatory cells will be there because they are repeatedly activated. So that being the case, sometimes even the seasonal allergy may also come down. So basically because of cross reactivity and cross suppression of the immune responses. So that's where the role of T regulatory cell comes. So this is where you use your basic information of immunology, that create some T regulatory cells, keep the antigens which is to be repeatedly exposed, and pick the desensitization through the repeatedly exposure, try to create the T regulatory cells. That's where you are likely to have much more prolonged effects. The other cells which are also used are T follicular helper cells, and they also, when they are exposed to skit or slit therapy, they start developing the plasma cells instead of IgE, the other immunoglobulins which blocks the IgE response. So in a nutshell, the clinical efficacy of allergen immunotherapy is, you can use it in monosensitization, bisensitization or polysensitization. You need to little consider the based on comorbidity, severity of the disease. Compliance is another big issue because it should be taken for a longer time of 2-3 years, and the route of administration need to be chosen based on the allergens that you have. Continuous or pre or co-seasonal, there are two methods which we use. If it is an allergen which is throughout the year, we use continuous. If it is seasonal, we use pre or co-seasonal. And the most critical and most biggest benefit you get, even if sometimes they may not be able to completely eliminate the allergic response, the severity, repeatability and the duration of symptom, requirement of hospitalization and quality of life significantly comes down. Especially when it comes to bronchial asthma, the patient who otherwise used to use every day 2 or 3 times puff may come down to use the puff once in 3 days or 4 days in a month. That's a big difference when it comes down to the patient who suffers day in and day out with the severe asthmas. So if things work out, patient may go for a disease remission or a total modifications. So what are the indications? What are the current guidelines that are available? This is the Indian guidelines. The allergic rhinoconjunctivitis, moderate to severe, mild, we hope it to go off. If it doesn't go off, watch for 6 months or 1 year. Even if the mild rhinitis persists beyond a year, better to start these patients on immunotherapy. The reason for advocating immunotherapy in mild to moderate rhinoconjunctivitis is quite a good proportion of these patients may evolve into the bronchial asthma, which could be more discomforting and can impair on the quality of life. Studies have clearly shown early introduction of immunotherapy in patients with rhinitis and rhinoconjunctivitis can reduce the incidence of developing them into the bronchial asthma. And allergic asthma control. This is one thing because patients should have a good control of. Patients who have a GNR 3 and 4 should not be used, but you should be they should be brought down, controlled, and then only you should introduce slit therapy. Large local reactions, atopic dermatitis, still evidence are lacking, but in some of the patients it can definitely help. So basically you look at the symptoms or sufficient duration and severity, allergen avoidance if not possible, that's a place where you use slit therapies, and availability of standardized best slit therapies. Not all allergens we have standardized SLIT therapies and SCIT therapies. We have for few of them, most of them luckily for the commonest antigens or allergens which we have. So if we have those allergens, antigens available, we can go ahead with SCIT therapies. The absolute contraindication is to use in the bronchial asthmatics where FE1 is less than 70%, and the malignant neoplasia. Pregnancy is something should not start when the woman is pregnant, but if the patient is already on allergy immunotherapy, you can continue that. You need not intervene or stop if the woman becomes pregnant, because we need to remember the allergens that you are using are something which we are day in and day out exposed. It's not something you have introduced a new chemical substance. The substance that you are using are the same. Avoidance of thing to initiate has been said that if there is a severe reactions can interfere in the continuation of the pregnancy, which none of us want to try at that point. One can introduce it because it has no teratogenic effect nor any other issues. The only concern, if you start at that time, if something severe reaction occurs, allergic reaction occurs, if termination occurs, and it's unnecessarily the allergist has to be blamed for. So that's one of the reasons why they say if pregnant, don't start the allergic immunotherapy. If woman is already on allergic immunotherapy, continue allergic immunotherapies. There are relative contraindication if patient is on beta blocker or a cardiovascular disease. Main concern is especially for SCIT therapy. SLIT we don't have much issues. In SCIT, if there is get a severe anaphylaxis, patient on beta blocker may not respond adequately to the adrenaline and other things, and patients with cardiovascular disease have a high chance of mortality, and patients with HIV is relatively contraindicated. A patient has a stable HIV disease, we can introduce these SLIT therapies. Psychiatric and mental disorder mainly because of the compliance issues, and chronic infections and autoimmune disorder, there are relative contraindications. If you have seen the case that what we presented, we did use both the combination successfully. So there are a lot of other new modalities which are coming in. So there is changing or modifying the antigens by using liposomal delivery, intralymphatic delivery, epicutaneous, ballistic. There are newer indications like food allergy, latex, and atopic dermatitis where studies and trials are going, using adjuvants to enhance the allergen responses, recombinant engineered proteins like recombinant purified, hypoallergic isoforms, etc., and genetic genic vaccines like cDNA, plasmids, and replications to alter the immune responses. These are the studies which are going. I mean, these are in pipeline. Hopefully in next few years they should be available for most of it. Just to give an example, the recombinant has a different way of administering when it compared to the conventional one. See, in conventional, if you could see that the gradual increase is done and maintained for a longer time. Here you can give a pass, give a pass because of the modified protein and a long stay of these antigens or allergens in circulation. So these are the changes or modifications which are thought of, which could improve the convenience of administration. So if every week or every third week, fourth week taking a prick, if you take 3 for some time and then give a gap and then come back again, so that are more comfortable and convenient with reference to that. So the other adjuvant therapies which are under consideration, that's adjuvant therapies, you give immunotherapy, simultaneously add some other to help and increase and improve the process. For example, you have vitamin D. Vitamin D supplementation, little in excess in the patients with allergy, can reduce the dendritic cell functions and also stimulate the production of IL-10. That's one of the role what we also think in autoimmune disease, using vitamin D, little in excess than what is required, promotes the IL-10 production. IL-10 production is a regulatory cytokines and downplays the inflammatory response. That's how supplementing vitamin D is one thing which we have considered. So it also increases production of Treg cells and regulate anti-IgE antibodies. That also helps in restoring the Treg cells and DC cells, and all others are still under studies. Probiotic is something we are still working. It's one of the field which is emerging. Still a lot of confusions and lot of issues to be resolved, but certainly probiotic going to have a major role in the management of allergic diseases. So the newer immunotherapeutic molecules are also going to come. You have adjuvants, you have recombinants, You have hybrid proteins wherein you can use combinations of two different proteins. So overall, with the advent of immunotherapy, which has evolved over a period of time, some of our varieties of regulatory reasons and available evidence, it is not used as much it should have been used. And I think it needs a long time for everyone else to get used to and get adapted to that. Thank you very much. The last slide shows the color, basically because it adds to the color of life, which could have been missed by avoiding certain things. Thank you very much.